All right, thank you for joining us today for this educational event on outpatient therapy for therapeutic activity. My name is Mary Sue Gardner. I'm a registered nurse on the Provider Outreach and Education team, and I'm going to be your facilitator for today's event. I'm also joined by Karen from Provider Outreach and Education, who's going to be helping me with the chat, as well as medical review representatives who will help with the chat as well. Housekeeping items before we get started. On our website, WPSGHA.com, we have a training center link at the top of that page. In our training center, you're going to find all things education, such as the training materials for this event, as well as the ability to sign up for any of our educational events. In the training center, you're also going to see a list of encore presentations, which is the recording of our live events, and you can actually watch those through our web page as we have a built-in YouTube player, so you don't have to actually go out to YouTube. So this event will be on that encore page within the next 15 business days. Those encores are generally on that page for about 60 to 90 days, but they're always available on our YouTube page until that information is either changed or updated. If you have any questions on today's event, please place those questions into the chat and send that to all panelists. And finally, if you have any feedback about your experience today, there's going to be opportunity event to take the survey. Karen's going to place a link to that survey in the chat now, and that's in case you find you need to exit the presentation before the end. I just want you to have the availability of the survey in advance. If you're listening to this event as an encore, we also encourage you to take the survey. The encore survey should be at the top right-hand corner of the screen. There should be a little eye with a circle around it. It's also going to be available at the end of the presentation, but a link is always available in the description. This on the screen now is a CPT copyright notice. Since there are CPT codes used within this presentation, I have to give you the CPT copyright notice. You can read this at your leisure. And this is our disclaimer that we have to give at every event. And basically our disclaimer says, the information that I am presenting today is as good as it is today. Medicare's laws, rules, and regulations often change. So as a provider of Medicare services, you need to make sure on the day of service you are providing that service to a Medicare beneficiary. You're following the most current laws, rules, and regulations that are in place. So CMS always has a final coverage determination. On your screen is just some acronyms that I may or may not use during the course of today's event. So if I happen to throw out an acronym and you don't know what it means, just refer back to this page. And if it's not on this page, just put it in the chat and one of my assistants, one of my co-hosts will send you out what that definition is. All right, let's jump into it. My objective for today's event is that as a provider of therapy services, you learn about the current review activities that are being conducted that include therapeutic activity, so the 97530. And you learn how to ensure that you're documenting correctly to support the services as you provide them. We're going to achieve this goal today by reviewing why the topic was chosen or identified for Targeted Probe and Educate. We're going to review the therapy coverage criteria and documentation, and then we're going to briefly talk about the KX modifier. So we've got a lot of information today, so let's jump into it. Now, the Targeted Probe and Educate process, that review program, it's actually designed to help providers and suppliers reduce claim denials and reduce appeals through one-on-one help. The goal is to help you, our providers and suppliers, improve quickly if you are chosen for a review. So we, as a Medicare contractor, we work with you to identify errors, to help you correct them. And really many errors are really simple to correct, such as missing physician signatures. So they're things that are generally easily correctable. Most providers will never be on Targeted Probe and Educate. So we use the data that is analyzed to identify providers or suppliers who have high claim error rates or unusual billing practices. And we use it to also identify items or services that have high national error rates and are a financial risk to Medicare. So providers whose claims are compliant with Medicare policy generally aren't chosen for Targeted Probe and Educate. So why review? Why did we choose the 97530, the therapeutic activities for review? So like I mentioned on the last slide, we use data analysis. Now, WPS identified these procedure codes, or this procedure code specifically. It represented a significant risk in total dollars at risk at greater than the 99th percentile, and the total dollars at risk per claim at greater than the 50th percentile when compared to other procedure codes within the jurisdiction. And the jurisdiction we're looking at for this happens to be J8 Part A. So the CPT code 97530 is billed based on time, with 1 unit standing for 15 minutes of therapy. So to assist us in making our review determinations as a MAC, we rely on the laws, rules, and regulations that CMS provides. For therapy services to be considered medically reasonable and necessary, they should be provided in accordance with the Internet-only Manual 100-02, Chapter 15, Sections 220 to 230. So that's the Benefit Policy Manual. And Chapter 15 and the sections are 220 to 230. And that a link to that is in the resources page at the end of this presentation. Now, these are the outpatient therapy regulations. However, they form the foundation of coverage for therapy. So if your place of service is somewhere other than outpatient, then you follow the outpatient regulations up to the point that your place of service specifies something different. So for instance, the outpatient regulations for therapy certifications are different than the certification regulations for like skilled nursing facility or inpatient rehab facilities. However, all the other rules still apply. So let's now talk about how this Targeted Probe and Educate works. All right, so after data analysis identifies a potential issue in a service that we as your MAC are paying and processing, then we identify the providers of those services that have the biggest potential to be billing in error. So remember on the last slide, I said this issue was identified because we found that it poses greater than 99% in total dollars at risk per claim and greater than 50% compared to other procedure codes within that J8A jurisdiction. So we take that information and then we have to drill it down to which providers pose the biggest risk. Once the providers then are identified, we then reach out to those providers to inform them that they are going to be on a Targeted Probe and Educate review. We really don't know if there is a problem with your claims until we look at the claims and the documentation to ensure that they are billed in accordance with Medicare regulations. So again, once we identify the top providers in the service that have the potential to be aberrant, we contact them to establish a point of contact. Then once that point of contact is established, we send written notification regarding the targeted probe and educate review. So it's a letter, it explains what we're reviewing, such as, what CPT code was identified, the reason they were selected, and all the information that the provider needs to know about the review process. As a provider, you have a direct point of contact with WPS as well. This point of contact is going to be the one notifying you of your results. They're going to be offering education throughout the process, and they're going to also offer one-to-one education at the end of each round to discuss any errors that were identified. So during the course of the review, WPS may reach out when we identify an easily curable error, like needing additional documentation. If we complete a review prior to receiving the additional documentation, we'll notify you of the intent to reopen our review and complete that review, including your additional documentation, if that should happen. We can also reopen a claim if we sent an ADR request for that claim review and you did not respond within that 45-day time frame. Those claims are going to automatically deny. And they're not appealable because there was no medical review decision. But if you send the documentation because of that accidental oversight and you miss that 45 days, we can reopen and consider the documentation for review. So during this TPE process, we can continue reviewing up to 3 rounds of claim reviews for any given provider. Once a provider facility has reached an acceptable error rate, we as your MAC will remove you from further reviews. We're going to continue to monitor routinely, monitor your data just to make sure you don't pop back up again in a data search, but we're going to release you from review. If you are a provider that continues to fail the reviews after 3 completed rounds of review and educate, then we will refer that provider to CMS, and then CMS will determine the next step to take with the provider. So now that we have briefly reviewed the TPE process, let's move into outpatient therapy criteria for coverage, because criteria for coverage is the same regardless of what therapy CPT code we may happen to be looking at. So there's 4 basic indicators that must be met for coverage criteria for therapy services. And these include, 1, a need-based service. So your patient or beneficiary must need the service, and that service must need the therapist in order to perform the service. So what makes the service need the skills and license of a PT or OT or SLP not in this case, but PT or OT to perform? If someone less than you and your license can perform this service, then it doesn't need you and it doesn't need your licensing and your expertise. The second one is services must be rendered under a written plan of care, and that plan of care needs to be established by either the therapist or the physician or non-physician practitioner. And the services being rendered to that beneficiary must relate directly to that established plan of care. Next, the beneficiary must be under the care of a physician. A physician order is not necessary, but certification of the plan of care is. Although direct access allows providers to treat a patient without a written order, under Medicare regulations, we still have to see that the patient's under the care of a physician. So we verify that generally through the certification process. We're going to talk about some recent changes coming up here in the next couple of slides. That leads me to certification, which is a fourth component of criteria of coverage, so certification. So in order to meet the conditions of coverage, we have to see that that physician certifies and when necessary, recertifies the services. So let's talk about maximizing your clinical documentation. We're going to briefly run through documentation requirements for all therapy services before we really start focusing in on how this documentation helps support the 97530. So, you know, having good overall documentation is just going to benefit you as a provider of Medicare services. All right, let's start with the required components of documentation, and then we'll talk briefly about each of these components. So the overall required components include evaluation and plan of care, any certifications and recertifications when those are necessary, progress notes, which include your discharge note and your daily treatment notes. So let's break these down. Start with plan of care. So this can be one document or it can be 2 documents. It can be 12 documents. We don't care as long as we have all the information that needs to be present. And we can see what your overall plan is that you're going to do to carry out and achieve your goals. So the evaluation and plan of care must include your objective information from your beneficiary, any test scores, any testing that was done during the course of evaluation, any functional performances, and your beneficiary's ability to participate. All of these things help encompass your baseline testing for your beneficiary and help support medically reasonable and necessary interventions by your therapist. Additionally, the evaluation must include any kind of pertinent medical or family history that could impact your overall plan of care. If cognition may be in question, you should address the cognition and its potential to affect those interventions that you plan on doing with the patient. We also need to see the amount, frequency, and duration. Those are things that need to be included. So what do you plan to do, how often, and for how long? All of this should be incorporated into formulating your patient's goals. Where do you want them by the end of therapy? And this brings me back to identifying why the skills of a therapist are required. So completing the evaluation, formulating a plan of skilled interventions and how they're going to be achieved, that really helps support why the beneficiary needs you, your license, your expertise, your skills, your therapeutic interventions. So it's your time as a therapist to sell yourself, to sell your skills, to show us on paper, you know, why it needs you. As we continue on with evaluation and plan of care criteria, excuse me, I got a little tickle in my throat. The evaluation and plan of care must be established by the physician or non-physician or therapist. And we're going to see, excuse me, that it was completed by the correct person by the signature and the credentials, which needs to be legible and dated. Per the regulations, it must be established before starting treatment. However, that doesn't mean you can't evaluate and treat on the same day. Most often, as the therapist is evaluating, they're having the beneficiary complete some treatment activities in order to help assess their abilities. Notes, you're jotting them down as you're going through and doing your assessment, and this is definitely allowable, but you need to really have your overall plan and evaluation completed before the next scheduled therapy session. So your evaluation and plan of care are periodically reviewed. This is actually what you're doing when you do your progress report. And that's not a reevaluation, but instead a component of regular treatment plan to make sure you are working towards the beneficiary's goals. So only, I said this before, but only a therapist, physician, or non-physician practitioner can formulate the goals, can formulate the plan, and they're the only ones who can make changes to a plan of care. So a PTA or OTA or CODA or therapy assistant cannot and should not ever alter a plan of care in any way, shape, or form. Finally, your evaluation and plan of care must contain the diagnosis, both the treatment and the medical diagnosis. That includes, we need to see long-term goals on there, but short-term goals as well if you write out short-term goals. It's always nice to see those when providers do that. And the type of interventions, what you plan to do, which includes your amount, frequency, and duration. All right. So the reevaluation. A reevaluation is not routine or recurring service. It should only be done in the event that there are new clinical findings that would significantly change the patient's established plan of care. For instance, if there's a new injury or illness or accident that forces you to relook at your patient and redevelop a new plan of care. Another example of that would be if the patient was hospitalized for a period of time during this episode of care due to like medical complexities, they probably need to be reevaluated because of those new medical complexities if they forced you to have to change your overall plan of care. Those are just a few examples. So if something happens to your beneficiary and you're forced to say, these are no longer realistic goals for this patient, then you should do a reevaluation and you should get paid for it. Again, when it's reasonable and necessary, we're going to pay you to do that reevaluation and you should be billed for it. However, you must remember continuous assessments of the patient's progress, which again, you're doing at the time of your progress report. That is not a billable reevaluation, nor is the end of an episode of care. So just because you reach the end of your episode of care doesn't mean you can bill a reevaluation. It's time for you to recertify with the physician, but it's not a billable reevaluation, which again leads us into certification and recertification. So the purpose of the certification and recertification is to obtain your physician's approval of the plan or the continued plan. So it must be signed, dated, and credentialed by the beneficiary's practitioner. And this can be, again, the physician or non-physician practitioner if they're able to do so in your state. But has to be someone with direct knowledge of this beneficiary and their case. So certification and recertification is required for each interval of treatment. So a treatment interval is the length of time the plan of care is certified for. At the end of that treatment interval, if continued therapy is reasonable and necessary, then a recertification is necessary. So by signing the certification and recertification, the practitioner's really given approval that that treatment and that treatment plan and the continued services during that interval that's going to be billed have been reviewed, and the practitioner is giving approval to you to provide or continued service as written in that interval. Let's talk about timing briefly. So the initial certification is due as soon as reasonable and practicable, but it must be obtained within the first 30 days of the start of care. Now, again, there's been some changes in what can be done on certification and orders, and we're going to get to that in a little bit. But again, the initial certification and recertification within the first 30 days of treatment. And excuse me, my computer is just making some noise, so I was just trying to turn that off. All right. And your certification is actually good for either 90 days. So that's the longest length of time it could be due for or good for if you happen to need 90 days and you know you need at least 90 days of treatment with that patient. It is good for the end of the duration of the plan of care, which means if you sent a request for certification for 3 times a week for 4 weeks, your certification is only good for 4 weeks. You have to get a recertification then at the end of that 4 weeks if you need to provide additional therapy. Or if there's been a significant change that warrants a new evaluation or a reevaluation. So anytime you have to do a reevaluation because of a significant change, you're going to have to recertify as well. So recertifications, as with certification, a recertification has to be by that physician or non-physician practitioner. And again, they're required at the end of the episode of care. And we went through that can either be 90 days or the end of the duration of the time that was certified by that physician or non-physician practitioner, or if there is a significant change that warrants, you to relook at that patient. All right, let's move on and discuss the next piece of documentation, which is the progress report or progress note. Now, if I were a therapist putting all my eggs in one basket, this is where they would go, because the progress report is really your time to shine. It's your way to report how your patient is performing under your prescribed plan of care, and if they're moving towards achieving your treatment goals. Or if they're not, this is your time to tell us what you're doing to update or modify their treatment goals to get them towards achieving their goals. This is how you support the medical necessity of continued treatment and the medical necessity of you as a therapist. We want to know why this beneficiary needs therapy, why they need continued therapy, and why it takes you, your knowledge, your skills, your licensure. And that's where you shine and tell us all the great things that you're doing. If the patient's making progress, if they're not, what are you doing to change that? What kind of new goals, what kind of new modalities, etc. So it has to be written by the therapist. It cannot be completed by anyone less than a therapist. It cannot be formulated by an assistant and signed off by you as a therapist. Your assistant can write a separate note that you take into consideration when formulating the progress report. But the progress reports themselves must appear to be completed by you. And if they don't, if it looks like an assistant completed it and you co-signed it, we will deny it, which means we're probably going to deny all the therapy services that were on whatever we were reviewing that day, that week, that month. think of the progress report as an extension of the initial evaluation and plan of care. The initial evaluation and plan of care can only be done by you, the therapist. It takes your knowledge, your expertise to formulate those plans, to modify that plan, to make those necessary changes, to introduce new modalities to achieve treatment goals, et cetera. So the timing of the progress reports, those must be at least once every 10 treatment days. It could be sooner, but not later. Recertifications do not affect progress report dates. They're not synonymous with one another. As a therapist, you should write up a formal progress note whenever you are due to recertify. That's just a nicety to your physicians to let them know where you are. My suggestion would be send the last progress report if it's not the timing, if you're in between that time frame. Send the last progress report, or send early for recertification. That's only going to benefit you. If you give it to them a little early, you have a better chance of getting it back timely. And finally, your daily notes. Your daily notes are a record of the treatment and the skilled interventions performed on that date of service. They are also used to justify your billing. That's why when documenting your daily services, we need to see what treatment was provided and the time associated with that, as well as who performed it. It must accurately be reflected on the bill as well. So the correct units and the correct modifiers, if modifiers are needed, and those would need to be included on the claim. So actual treatment minutes need to be in your documentation because they are used to support the amount of units that actually go on the claim. So we have to verify the amount of units versus the actual treatment minutes. It is in your daily notes and your bill to Medicare that we're going to see the use of the 97530. When we verify us on the claim, and we're going to look towards your daily treatment notes and make sure that those line up with each other. And we're going to make sure the amount of units that are on the bill are the same as the amount of minutes that are documented. So we would expect the daily treatment notes to be reflective of the actual time and exact minutes provided. So let's move on to the 97530 itself. So in the CPT coding manual, this code falls under physical medicine and rehab. It's a therapeutic procedure code. And in the description, a manner of affecting change through the application of clinical skills and or services that attempt to improve function. That's all how it starts formulated in the CPT book. It requires direct one-on-one contact. Again, CPT code 97530. It's a time-based code. It involves direct one-on-one patient contact by the provider, utilizing dynamic activities to improve functional performance, with each 15 minutes constituting a billing increment. So this therapeutic procedure focuses on, again, affecting change through the application of clinical skills and services that are aimed at enhancing overall function. Therapeutic activities are directed at addressing limitations. Limitations in mobility, limitations in strength, balance, coordination. So when you're thinking about using the 97530, you should focus on those tasks that end in NG. Lifting, handling, reaching, transferring, transporting, all of those things to improve the overall function. So specific examples include like hand assembly activities, transfers like chair to bed, lying to sitting, etc., swinging, catching, lunging, throwing. In contrast to therapeutic exercises, which uses like one parameter, like strength or range of motion or flexibility. So when documenting the 97530, patient's condition that's justifying therapeutic activity. So we're ensuring accurate documentation begins with a thorough assessment of the patient's condition. So this goes back to your evaluation and your overall plan of care. You need to really clearly articulate the specific functional impairments or limitations that necessitate the use of therapeutic activities. Those, again, those ING words. Include detailed information about the patient's medical history, those diagnostic findings, any relevant clinical assessment. And then your patient's inability to perform activities without direct supervision. Document the patient's inability to engage in therapeutic activities without direct supervision. So this involves demonstrating why one-to-one interaction with a healthcare provider is really necessary for that safe and effective execution of the prescribed activities. So emphasis on any safety concerns, any risks, any limitations the patient may have that require direct supervision. Again, these are things that we're going to see a lot of this starts to get formulated in your initial assessment and your overall plan of care. And then as you start to do your progress notes, we're going to see this kinds of information directly reflected in your progress report as well. So again, when documenting the 97530, clear correlation between the prescribed activities and the medical condition. So establishing a direct correlation between these two is crucial. So you need to clearly articulate how these activities contribute to addressing the identified functional impairment. Again, going back and thinking about your overall assessment and plan of care, and then your progress notes is, again, we're going to find a lot of this information. You need to include specific details on how the chosen activity aligns with the patient's treatment plan and goals. So you do that to ensure, you know, a comprehensive understanding of these therapeutic interventions and the relevance of them. So best practice is determine outcome is expected from your task. That's your goals. Your documentation needs to include the specific focus of the functional tasks or activity and should be clearly, again, identified in your overall goals, and that's going to help support the use of the 97530. So on your screen is just an example. So PT facilitated forward reaching activities at 90 degrees of shoulder flexion. The patient was given 4-pound weight on bilateral wrist and simulating item retrieval from shelves and placing the item on the floor and returning it to the shelf. Now we're seeing a lot of ING words, placing, returning, lifting, etc. Patient performed this activity 10 times, one set, with a report of some anterior shoulder discomfort by the 7th attempt. So patient did require 25% verbal and tactile cues to perform the proper lifting techniques following rotator cuff injury. Patient graded, or PT graded the task after 5 minutes of a therapeutic rest break, then retrieved items at 125-degree shoulder flexion and reaching. So they had similar discomfort on the 4 trial, and patient was educated on various relief techniques at home. So that's just an example, you know, and you can see all those different ING words that help to support this as the 97530. All right. So before we conclude the day, I want to just cover the KX modifier really quick because the KX modifier is important in your overall outpatient therapy billing. So it's a payment threshold. It used to be called the therapy cap. Therapy caps no longer exist. Instead, the KX modifier, it still exists, and it still has to be appended when your beneficiary reaches a certain monetary amount or monetary threshold in their use of therapy services. So when your beneficiary is at or getting close to the first therapy threshold, which is $2,410 for PT and SLP services this year, and $2,410 for OT services, you need to start appending that KX modifier to the outpatient claim. That lets us know that you've reached that threshold amount, but the services that you are providing for that beneficiary continue to be medically necessary for that beneficiary on that date of service. So there's a second monetary threshold amount as well, and that's $3,000. You just need to continue to append the KX modifier to your claims if you reach that amount. Again, PT-OT is, or PT-SLP is combined at $3,000 and OT at $3,000 themselves. And that's a set amount till 2028. The lower amount changes every year. So at this amount of spending, your claims are subject to medical review. So the SMRC contractor, or the supplemental medical review contractor, they're the ones who actually conduct those reviews. So they would actually reach out and request documentation submission for claims that exceed that amount. However, mean that that every claim that hits that threshold amount will be reviewed, because there's no way possible they could review it. So, you know, it's a small number of claims that get reviewed. If you've been identified as an outlier, you're more likely to get reviewed. If you're a brand new therapist that really doesn't have a lot of billing under your sleeve, you're more likely to get reviewed. So again, keep in mind that these limits are based off of incurred expenses, and that includes the applicable deductibles and coinsurance. So when do you append it? I basically covered that on the last slide, but let's reiterate. You start appending that KX modifier to your outpatient claim when that incurred therapy expense reaches that first threshold level of 2410. And that's combined PT-SLP or 2410 for the OT. And even if you surpass or get to that 3,000 mark, if services continue to be reasonable and necessary, you continue to append that modifier. Again, this applies to therapy services regardless of if they're rehabilitative in nature or if they are maintenance. Now that takes us to the end of our formal presentation. These are just resources that you may find helpful. And just a little recap, because I know we're at the end of our time and I want to address the few questions that are in chat really quick. But today we went over why we're doing that TPE, especially with that focus on 97530. We achieved the overall goals of talking about the targeted probe, why providers were selected, and then gave you additional information to help if you're ever selected for review to help identify what a TPE is. We went through the coverage criteria, we went through overall therapy documentation, and even the KX modifier. So that was a lot of information. I know we are at the end of the time. So if you are a provider that needs to jump off because of time constraints, you can do so, but I'm just going to take a quick look at the chat and cover some of these questions that are in there really quick because I don't want them to go unanswered. So there was an early on question, said something about meaning 99% of the time people are billing the wrong CPT code. A bit confused on that language. I'm not sure, Kelly, what that CPT referred to. So if you want to give a little bit more information in the chat on that one, we can definitely get that answered for you. The next one is, does a physician need to certify the plan of care prior to the start of therapy? And the answer to that is no. And the piece of missing information that I and sorry that I skipped over that I want to reiterate before the end of our session today is that for calendar year 2025, CMS finalized some amendments to the certification regulations to lessen the administrative burden for therapists, so PT, OT, SLP, and to eliminate or lessen these burdens for the physician and non-physician practitioners as well. These changes provide an exception to the physician, non-physician practitioner signature requirements on the therapist's established treatment plan for the purpose of the initial certification. So in the event, in the case where you receive a written order or a referral from the patient's physician or non-physician practitioner to start therapy services and to evaluate and treat, and that is, you have that order on file, and it's documented, as long as you send that treatment plan to that physician and keep documentation that you've sent it to them within 30 days of the initial, within the first 30 days of treatment, CMS has said if you don't get that back within that 30-day time frame, it is okay to consider it certified. Basically, the physician has sent you an order for evaluation and treat. You have that order, you can keep it, and you do still need to send the information on the overall plan of care to that physician, and you need to keep that on file as well. But if you don't get it back within that 30 days, it still is considered certified. So again, that information is in the OPPS final rule for calendar year 2025, but I wanted to make sure everyone was aware of that. All right, so does a physician need to certify the plan prior to the start of therapy? Again, that answer is no. The next one is the KX threshold based on charges or reimbursement? So that KX threshold actually is based on the incurred expense, so the actual charges. I believe that's how it is. And Karen, if I said that right or incorrectly, you can correct me. So again, that includes the applicable deductible and coinsurance as well. Let's see, the thresholds are for Medicare allowed amount, not charges. Yes. Okay, so how are the TPE processes different between single CPT codes like 97530 and simple TPE for the use of KX modifier? Is there different criteria or different things that are being looked for? And the answer to that is, for the most part, no. We're still looking at your overall therapy services. There's different things in different providers' billing that drive that specific targeted probe and educate. And that's why I covered all of the documentation and coverage criteria, because the things that you need to have in your documentation to support your services are no different if you're being looked at for 97530 or if you're being looked at for the KX modifier. So there are different outpatient therapy, targeted probe and educate reviews that are going on in different jurisdictions in different parts of Medicare. At the beginning, you talked about the 99% risk for 97530. What is the 99% risk, or what does that mean? It's towards the, okay, so the very beginning. So this was when they did the initial data analysis of claims that we pay and process as a Medicare contractor. So when the initial, we have to periodically keep reviewing what comes into us as your Medicare contractor. Our data people started noticing a lot of claims with the use of this procedure code, 97530, for our providers in the J8 Part A jurisdiction. And of that, it's 99 percentile dollars at risk. So the total Medicare dollars that we pay out, this falls into the top 1% of the total Medicare dollars that we pay out that are at risk. And the total dollars per claim, so each claim that has that is greater than the 50th percentile. And then the final question was, the burden reduction is only for initial certs, not research. And the answer to that, Chris, is yes. So that is only, that is only for your initial certification and not for the recertification. You still have to have your recertifications timely. They still need to be signed by the physician. So if we have a written order for PT and send the plan of care to the MD, but did not receive it back, signed and dated within 30 days, we do not need to get a delayed attestation. You are correct, Lucia. Yes. All right, and that, I know I've kept you over, so I appreciate your willingness to stay, because I think these questions were really important to hear the answers to. And hopefully if people had to jump off early, they can listen to the question and answer section from the encore. But I'm going to proceed now and just kind of talk about the end of the day. So you probably already have an email in your email box if you logged into this webinar. Don't delete that email without reading it. It not only has a link to the survey if you want to take the survey in that manner, but it also has your certificate of achievement if you need that for CEUs. So again, we encourage you to not delete that until you formally read it. If you have any follow-up questions or anything I didn't get to, go ahead and send them to our email address, wps.gha.education@wpsic.com. If you have the slide deck, if you click on this, it's going to formulate an email for you, and it's going to put the information of medical review therapeutic activities in the subject line for you. Send those within the next week. But if you have a question that's in regards to something on your claim, something that needs to be looked up on a claim, we cannot do that in provider outreach and education. We do not have access to those systems. And we definitely don't want you to send any PHI or PII over the internet and, have a potential finding by either you or us. So if it is claim specific, please go to the claims department or customer service with those. Again, I mentioned the survey. Your opinion does matter. I want to know how you feel about this. Please take the time to take this survey and take it to the end. I know some of the questions get a little long-winded. It is a CMS survey, but they do rate us on these surveys. And so not only do I want to know how I did, CMS wants to know how I did, and if you feel this was valuable. It's also your opportunity to tell us what other education you need in the future. So if everything was great and you just want to tell us what else you need in the future, go through, say everything was great, and here's what else I wish you would provide, because we take all of those suggestions into consideration. So on behalf of Karen and myself, as well as Medical Review, I want to thank you for sticking it out with me today, but I also want to thank you for your participation in today's event. This concludes our formal webinar, and you may now disconnect.